Blog Talk Radio.
Welcome to the Texas Conflict Coach radio program. If you have ever experienced or engaged in destructive or unresolved conflict, then you know it leads to broken relationships, distrust, and damaging results. Our program will help you manage and resolve conflict effectively with strategies, valuable resources, and support. I am your host, Patty Porter. My guest hosts, Dina Zameta and Stephen Kotev, along with our guest experts, will share our experiences, raise your awareness, and give you food for thought. We will share with you problem-solving strategies no matter what your situation is. At work, with neighbors or friends, family, and as partners. Tune in or join in the conversation every Tuesday evening. Good evening, listeners. What we have is talking about a good death and what constitutes a good death. How and where are people dying? Are the needs of the dying being met? And how can we advocate for a good death? Considering we are all going to die and lose loved ones at some point in time in our journey through life, these are all important questions to explore. Recently, there has been an increased emphasis on the importance of addressing healthcare disparities in the end-of-life care, and you can only imagine what conflict this creates. This increased emphasis is mostly as a result of bountiful research on how dying patients are invisible in many acute healthcare settings in the United States and are victims of healthcare disparities. That is, certain groups receive lower quality of care than others. Worse than being a dying patient is being a dying patient who is perceived by medical personnel as belonging to a different race, a culture, an ethnicity. And of course, these biases that lead to disparate treatment are often present at a very subconscious level. So in this episode, starting the conversation, reducing healthcare disparities in end-of-life care, I have with me Dr. Jacqueline Font-Guzmán, and she will share her latest ongoing research on ways to address these end-of-life healthcare disparities through conflict engagement processes, such as World Café Dialogues, and some of the challenges. And what can you do to improve your and your loved one's quality of end-of-life care? So very interesting conversation. I'm really excited to having Dr. Guzmán on the show from Warner Institute. So a little bit about her. She is the associate professor at the Warner Institute and a member of the Center for Promoting Health and Health Equality at Creighton University. She is a Fulbright scholar who has actively participated in the field of conflict studies through national and international conferences and leading a wide variety of trainings and seminars in the field. She does conduct qualitative research with a focus on healthcare disparities and conflict engagement, and specifically how people construct meaning at critical points in their lives about their identity and the manners in which meaning-making leads them to productively engage with conflict. And she also explores how marginalized individuals create alternative stories and counter-narratives to address institutional justices. So there's a number of things on our program page about Dr. Guzmán where you can view her research, and we'll give you a number of websites later on, but you can also connect with her on LinkedIn. So we do have our chat room open on Blog Talk Radio. A number of you have already joined us there, so thank you for doing that. We encourage you to write your questions and comments in the chat box there. I'll bring it into the show with Jackie. We also invite you to participate in our Twitter feed using the hashtag TCC Radio. So Jackie, welcome to the show.
Thanks you, Patty. I'm really happy to be in the program and your invitation to share some of my experiences about a topic that I'm actually very passionate about.
Well, we're going to talk about that passion. You know, we've been a long-term partner and fan of Creighton University and Warner Institute and ADRhub.com, and so I'm glad that you, as one of the faculty members, as part of that for us. And so let's talk about this passion. What got you into the work of death and dying in the first place?
It goes way back. My journey with this topic probably started without me knowing it when I was around 10 years old. And I was living in Puerto Rico. I'm originally from Puerto Rico. And my mom, a psychiatrist, decided back in the 70s that she was going to help patients die. And this was back when death was taboo. I mean, death was not something you talked about, especially if you were a physician. So she also kind of figured out that it would be helpful for me to learn about life by learning how people die. So I began to tag along when she would go to, sometimes at hospitals, sometimes at people's home, to help people die. And even at a very early age, I started noticing that there were some striking differences in the way these dying patients were treated. So, for example, if it was in the hospital setting, they always would occupy different spaces. It was like if they were hidden from the rest of the hospital population, either a different ward or a different floor. And it wasn't not only the physical segregation, but it was also this awkward silence that always would surround when a patient was dying. And it was almost like they were not there. We didn't want to acknowledge that they were there. And that felt very different even at an early age when you would go and visit a patient that, for example, had just had surgery. So I think that's what sort of started me into this healthcare and end of life. I mean, thinking back, way back at that age, you don't really see it that way.
You know what strikes me when you tell me that story as, wow, you must have been a courageous child, because a lot of children would be very scared of, doing that. And it seems like you went from a place of, and I'm not saying you weren't scared, but it seems like you went from a place of real curiosity. So that was really striking, how fearless or courageous you really were at a young age in dealing with this and observing that and helping your mom.
I think more than, it's funny because in our field, we talk a lot about the importance of being curious. And I think one of the things at that age is that, you're kind of fearless because if you're more curious than fearful. And so I think that whole concept of reframing in our field, it was never framed as something scary. So I kind of didn't know anything different in a way. So that I think that's another way that our field sort of plays into this.
Well, it was a natural progression then for you as you developed in your career. And so let's talk about, we talked about in the introduction about a good death. Is there such thing as a good death, and how do you define that?
That's actually a great question, because people die in all sorts of ways. Some people go down fighting for life all the way to the end. Others want to die quickly. You talk to them and they say, I'd rather be like just walk down the street and be hit by a bus and done, right? And others, they want time to say their goodbyes. So there isn't really one good definition of death. For me, a good death is one in which your wishes are honored and they can be shared. So whatever is important for that dying patient that needs to happen, that happens when they come to that stage in life. Now, having said that, there is some research and literature being done and about what is a good death. And there's three main themes that usually surface in the literature. And one of them is a good death is one where you die at home and you're surrounded by loved ones. So it's the sense of community, the importance of having a community supporting you, however you define that community. It could be family members, it could be in a hospice, it could be in a healthcare facility, but there's a community there that is walking you through this. And the second thing is a life well lived. People who cherish what was life-giving. So the fact that you can continue to do what you're doing and that is life-giving to you all the way to the end seems to be something that is very important in terms of how you die. So, for example, I was talking to a patient some time ago who had refused a specific treatment because a possible side effect of that treatment was the need to be nourished through a feeding tube. And for this patient, a life well lived included sharing a good dinner and drinks with friends. So that was something that would have been a terrible death for that patient had he been, with a feeding tube. And then contrast that with other patients that are, maybe elderly, have grandkids, and they say, I'd rather have the feeding tube because I want to spend every single second I can and maybe see that graduation of my grandkid or maybe see my son reach a milestone. So however we define that life well lived to the end seems to be another common theme. And the last one and third, which is pretty, I guess common and obvious, but it's a pain-free death. Being able to die without being in pain. And again, there's many others, but those seem to be the main three issues that define, or people are defining as having a good death.
So even though the research has these themes that are coming across the board, I'm also hearing it's also very individualized based on people's experiences in life and their values and stuff. One thing I did want to clarify for the listeners when we were initially talking about the definition of good death is that you said their wishes are honored and shared, and we're talking about their wishes when they're still alive are honored. This is not about their wishes after they're dead. Is that right?
It's interesting because, we as humans want to have this sense of control. And so actually it's kind of a layered question here because one of them is, yes, you want to have control over what you do while you're living and how to make decisions. But there's another part to that, which is, what about if something happens and I can't decide? I still want, even though I'm unconscious, for my wishes to be honored. And that's when a lot of the work that's being done now with advanced directives and powers of attorney and documents that you can sort of in writing say, this is what I want, these are my wishes. When I can no longer express my wishes, I want someone to step in and honor them.
And honor them and stick to them. Okay, so we've got a definition. We have some research, some themes that are happening, pretty individualized, and where one person might want this or define this as a good death might be a not so good death for another person. So we know that and that from that. Now, from your own personal story as a child, having experienced, people that were dying and your mother kind of walking you through that, and then you have this career background in healthcare and you've seen a lot because you're in conflict engagement processes around these disparities in healthcare that seems to not give people all equal footing in terms of having this good death. So first of all, could you define what these disparities are, maybe give a couple of examples?
Yes, and I think it's very important before we go into that to sort of distinguish a little bit three terms that are usually conflated when they're talking about disparities. And so I'm just going to very briefly define them so that we're all on the same page.
Okay.
Disparities, there's disparities in health, there's disparities in health care, and there's health care inequity. And these three terms are usually brought together and used, without really distinguishing one from the other. And so disparities in health is differences in health outcomes and status. For example, you have two patients, they have the same disease, let's say it's cancer, they're at the same stage of cancer, but one maybe is a woman and the other one is a man, and one lives 10 years and the other one lives 5. So there's a difference in the outcome, or what physicians call prognosis, right? Even though they have similar diseases, similar stages, similar conditions. And that's just a disparity in health. And that could happen just because of an array of reasons. It could be the diet that they have. It could be the exercise. So it could be many things that factor in that, outcome or status of health. Okay. The part I am really interested in is the disparities in healthcare. And a healthcare disparity is the unequal treatment of patients, but on the basis of their physical characteristics or because they belong to a certain group. So, for example, let's take the same example. Two patients with same diagnosis and similar conditions, but one maybe is Latino or African American and the other one is American. The literature and a lot of the research done inclusive, even by the Institute of Health and the Institute of Medicine, what shows is that some people are going to get better treatment than others just because of the way they look, okay? And that's a lot of hidden and unconscious biases. It's not that the physician when you walk into the emergency room, they're going to consciously say, I'm not going to take care of you. I'm going to take care of someone else. It happens, it kicks in on an unbiased level, but also, and for me the most important part and the most interesting challenge in here is it could be structural issues. So, for example, one has insurance and the other one doesn't have insurance. So even lack of access to health care is an example. So and this is usually appalling and it's outrageous that it happens because it's really unnecessary and it's avoidable. So it's something that is distinguished, that is unfair and is unjust, and yes, it's taking place.
All right.
And that is the area that I'm usually more, and that's my area of focus, how to eliminate those discriminatory barriers within a system. How can we take this disadvantaged or minority groups that receive poorer health care than others, and how can we overcome those barriers, right? Oh. And maybe if I give you a specific example, it would be better. So, for example...
And can you clarify one other thing before you do the specific example?
Sure.
You said the definition number 3 was health care inequity.
Well, inequity, right. And those are the ones that, again, it's an unjust or unfair situation. So it's a lot more related to the healthcare disparate treatment. There's a difference in treatment, and there's really no reason for it to be different, right? So they really should be receiving the same type of treatment, but they're not.
Okay, and then the last clarifying question is your research based on the system in America, or does this also include, social systems like in Canada, for example?
I haven't done a comparison with Canada, so I wouldn't be able to tell you that. But the issues of disparity, in fact, I was just at a conference a few months ago in Costa Rica on bioethics. And this issue of disparate treatment varies from different, depending on the cultural context or the nation you're in. My focus has been looking at what has been happening in the United States. How are these dying patients being treated within the healthcare system?
So you had an example.
Right. So, for example, there's a lot of empirical research and data out there that states that African Americans and Latinos are less likely to receive adequate pain control, which, if you look back, that is one of the definitions of a good death, to die without pain. Okay. And we know, based on the research, that this group of patients are less likely to receive this adequate pain control. And a lot of it, and some of the articles are stating that it's because there's this unhidden biases and assumptions that, for example, African Americans are tougher and therefore they can resist pain more. And that's a disparate treatment because it shouldn't happen. Another example is, again, on African Americans and Latinos, which is where I've been focusing on, is they have lower rates of hospice utilization. And so hospices are, places where people go when, according to their prognosis, maybe they're going to have 6 months or less of living. They go to a hospice where they're being given, pain medication, control, so basically helping you, die in those last days. Well, African Americans and Latinos have lower rates of using those type of services. So again, if we go back to what's a good death, and one of it was having a community of care and support, this is another disparate treatment that is happening. So those are two examples. There are many others. They're also less likely, and this is interesting because it connects with the issue of how this has become ingrained in the healthcare systems. For example, they're less likely to have advance directives. They're less likely to fill out documents that say and have conversations about, this is what I need to, this is what I want to happen when I cannot make a decision. And they are also less likely to talk about do not resuscitate orders. Now, why is this important, right? Why should we care? What is the impact? Well, to the extent that your wishes, first of all, to the extent that people don't know your wishes, they cannot honor them, right? Second, you also end up receiving unwanted and even worse, futile care. Treatment that is really not helping you, which in turn increases the cost of healthcare. So there's some real implications, not only in terms of just, our role as care providers and as society to be able to care for those that are more disadvantaged and not have them die in pain or without a community of support. It also has a direct impact financially in our healthcare system.
Okay, so these are just two tiny little examples, and they're big examples in and of itself because there's hundreds of examples. I can imagine we hear about healthcare issues all the time, and I appreciate the fact that you're defining it, especially in your research around Latinos and African Americans. Now, this whole show is about conflict. So people are like, well, what does this have to do with conflict? And your career at some point intersected with a study of conflict management. So before we go deeper into that, I just want to let listeners know, again, thank you for joining us in the chat room and the Twitter feed. And you are listening to the Texas Conflict Coach radio program. And we're talking with Dr. Jackie Font-Guzmán with Warner Institute at Creighton University. And so as we move along here, say whatever you would like to say in terms of how your career, your healthcare portion of your career intersected with conflict management and how you're using your expertise in those two areas to really start addressing these particular issues.
Yes. For me, conflict is what sort of brought it all together. So I originally went and got a master's in healthcare administration, and I knew I didn't want to be a clinician. And I think part of it was because I was trying to lead people into change, trying to see how those gaps could be, somehow reduced. And I figured, well, going to healthcare administration, maybe you can do it. And that was a satisfying career, but there was something missing. And I figured, well, maybe what I need is learn how to advocate for this group of individuals. And so I went into my legal career and got a JD and did some litigation for some time in the healthcare area and other areas. But, of course, unsurprisingly enough, I found out quickly that to change a system, and that's what we were talking about, it was a healthcare system. It was a system and institutions within society. You needed more than advocacy. That by focusing on an individual client, I was only going to help that individual client. I wasn't going to make a change in the system. And so I started getting into mediation and doing mediations, and I said, maybe there's something here. Maybe this is what I'm missing. And so one thing led to another, and before I knew it, my curiosity once again led me into getting a PhD in conflict studies. After having said, when I was done with my law degree, I said when I was done with my master's, I said I'm never, ever going to study again. And then I went into my JD and I said, I am done this time. This is it. And then somehow I ended up being in a PhD. But now I think this is it.
I think X marks the spot. I think you got it in terms of the combination of those things and the journey in getting there to find what it is you need to do to help change the system. So what is that you are actually doing to address the system?
So what I'm actually doing is, and partly part of the reason why conflict was such a good fit is because, for example, in legal career, conflict is dehumanized. And there's a lot of tunnel vision. Everything, you have complex issues like life and death that are reduced to a statute. And I wanted more than that. So I did my PhD, and I started working recently in the last few years, and this is actually a work in progress, with a colleague of mine, Dr. Helen Chappell, from the Center for Health Policy and Ethics, also at Creighton University. And we got together and decided to tackle this a little bit more. We get an internal grant from Creighton University, and we started looking at death. What is it with death? It's usually considered a private matter, right? I don't want to talk about it, and if I do talk about it, I'll talk in a very small group because this is a private issue. And we started looking at it and saying, you know what? All of these people are underserved populations, and they're all underserved populations, and part of it is because we're not looking at this issue of death and dying from the vantage of public health. Who are those that are dying? Are their needs being met? What is a good death, right? So we started looking at this, and then my colleague who had done extensive experience, working with a lot of this, she said, It's all about the conversation. And actually, we have a website which is called "It's All About the Conversation." So if you go there, you can get some more information. And it's not really the legal document. It's not really filling out a form. What actually helps is having the conversation. So how do we have this conversation, right? How do we prepare people to have this conversation? What are some of the structural barriers for Latinos and some of those minority patients to be even further discriminated? So it's bad enough to be dying, but now it's even worse if you're in this group. And we started asking all of those questions and figuring out how we could do it. And the research, it was a part of a larger issue, but we said, you know what? I have the answer. World Café Dialogues. Let's bring in people into a room and have World Café Dialogue conversations. And that's where this conflict process comes in. In one of my articles that was recently published last year, which is called Beyond Neutrality, I sort of make an argument that we sometimes as conflict resolution practitioners are not called upon to do certain jobs or work because we're so focused on neutrality and in individualizing a very systemic issue. So we think if we provide training to physicians on cultural sensitivity, that somehow then that's going to solve the issue. And in my experience and my personal opinion, these people are not being treated, not because the physician is being culturally insensitive, but because of the structural barriers. It's because of racism that has been. We were going now in our nation through a lot of conversations about racism and violence. It's ingrained within our system to the extent that sometimes we don't even see it. So it's really about unequal power distribution, in which certain groups are not being allowed to fulfill their basic needs, like well-being and identity. And Galton talks about, he's in our field, talks about how this is structural because it's ingrained in the political systems. And so how do we unveil that? And that's where I brought in my conflict resolution expertise. We do it through World Café Dialogue process.
So the thing about, one of the many things that you brought up that stands out is oftentimes because so many people are fearful of difficult, sticky conflict conversations, and so not the prognosis, but the treatment, if you will, is let's do training. And like you said, and whether that's in the workplace or, systemic, issue, policy-wise, public-wise, healthcare-wise, whatever. And like you said, really, we don't really address what's core of those structural barriers, as you mentioned, are core at the issues that are really going on in a workplace organizational setting without having those conversations that are critical to have. And World Café, folks, listeners, you've probably heard us mention World Café a number of times before in the past, and it is a specific dialogue process issues. We won't outline that right now, but it is a dialogue process to really open up those conversations to large groups of people, especially when you're talking about systemic change and having those difficult conversations. We have now, Jackie, about 5 or 6 minutes left in our program. And what I wanted to ask you is, in these difficult conversations that you are using the World Dialogue Cafe process in, what are some of the stories that you are learning from in these discussions? Because it's not just physicians, it's every kind of stakeholder that's involved in the system, right?
Exactly. And that's why World Cafés are perfect for it, because World Café, as most of our audience that is in conflict will know, works best when the more diverse groups you bring into the room, and the more people, the merrier, right? So we've conducted 4 World Cafés in Nebraska. The last one was actually in Spanish last week, and what we're doing is, and some of the stories are fascinating to begin with because it's a safe space to talk. So a lot of the stories are, and some of the things I've learned is concerns about timing. So, for example, one person, and I actually put some quotes here just to share some of those stories, said, I guess a question that keeps on popping back into my mind and cycling through and not having the answer is that question: when is it appropriate to introduce the conversation about end of life? And then the conversation went on about, well, probably the earlier the better. And one of them said, when you're a kid. And it brought me back to, that's when I started these conversations. So there were some really interesting stories around timing, the importance of listening for those of us who are in the conflict field. One person actually brought the story about, I would like to say, and I'm quoting, I would like to say a theme that I'm seeing is that we need to listen more. We need to be more present when we're next to those patients and families. Whether we are in there for 5 minutes or we were in for 2 or 3 hours, we need to do that. As we need to do that, whether we're in the hospital setting or out of the hospital setting. So there was a lot of, because some of these conversations happened with, and what's interesting and fascinating about this process, these are like this aha moments that people have in the middle of a conversation. And what this dialogue does is, it's not that they're learning new information, it's that they're tapping into it and it's surfacing to a place where they can have a conversation, which is what's fascinating. And the reason I got IRB approval, Institutional Review Board approval, so we have been tape recording all of these conversations, transcribing them, and we're still in the process of figuring out what are the main themes that are surfacing. So like I said, it's a work in progress. Some of the other stories were about fear, and a lot of the fears were, for example, fear of not doing enough. I think families are afraid to know, one person said. And when my father-in-law passed away, the children were so afraid they hadn't done everything they could. So to the extent you don't have the conversation, people don't know if they're doing the right thing. And it also goes back to mistrust. In the case of African Americans and Latinos, because of the history of violence and experimentation that has gone, that they have suffered, they don't trust the system and they don't trust the structure. So this is such an excellent way to surface a lot of those fears, to have a conversation about them. The other great fear, and I'll just do this last one and to share, is fear of stepping out of the saving life norm. So healthcare works, I need to save your life, and if I cannot save your life, then I'm useless, so I'm ignoring you, or I'm putting you aside, or I'm setting you aside. So there was this great quote about, it says, it became taboo because everything in medicine is about curing. We heal, we treat, we cure, we save lives. And the second you're out of that paradigm, then what do we do? So those are some of the stories that have surfaced. But again, we're in the process of steaming all of this. It's like hundreds and thousands of pages of, transcriptions.
Yeah, and dare I say, at the end of the show, dare I say, assisted suicide, right? I mean, so when when the healthcare system's fear is about, curing, treating, saving, and then you have this whole new thing, and I don't know if that's even part of your research or dialogue or if it's even come up. And I know we don't have time to talk about it, but boy, was that what popped in my head, that people want to have a good death, and maybe their good death, like you said, is being free, pain-free from death means assisted suicide, which is another controversial, conflictual issue. And I don't know if that's come up in your dialogues or not. Have they come up in your dialogue?
It has come up in the dialogue. Actually, there's this very striking, because people are fear of talking, and many people raise the issue of, well, we keep on trying because we always think there's something to do, so we never want to talk about it. And the assisted suicide is a lot depends on your religious, what your religious background is. So that's going to depend on where you're coming from in terms of your spiritual or religious convictions. But there was this one sentence which was great, and one of the participants says, and I'm quoting, "When you make room for death, you make room for conversation." So
wow. When you make room for death, you make room for conversation.
Room for conversation.
Wow.
And if the patient cannot talk, you can make room for family to have a conversation. So, I mean, those are just this incredible, powerful insights and experiences that people are sharing, when you put a lot of people in a room and in a safe space to just cross-pollinate ideas.
So we always, in our closing, give listeners a call to action or a field work assignment. And since we've been talking about making room for conversation, It's all about the conversation, which I just went to the website right now, and for those who are listening right now, and I put it in the chat room, it's called It's All About the Conversation, spelled out just like it sounds with no apostrophe. It's ITALL about the conversation.org. So what is it you have, Jackie, for folks about this conversation that we really need to be having, and maybe some primer questions to get them started? What do you have for them?
I would encourage people to first of all look inside and think about, start with yourself. What do you think are your wishes? If you are in a position of privilege somehow, what are those privileges that you have that maybe others don't have? And how can you help and facilitate, address some of these barriers of structural violence that exist by having the conversation? Conversation is the first step. Unless you are aware of something, you cannot change it. And so go there, be proactive, think about what do you value? What is life-giving to you? Because again, based on conversations with many people and some of the work that's out there about patients in their last days, that's where it comes down to. You don't remember the day that you had to stay until 5 a.m. in the morning working on a deadline. What you remember and cherish is forming those communities. Form your own community, form your networks, figure out what is it that's life-giving to you, and whatever your wishes are, educate yourself. Go to some of these websites. What is a power of attorney? What is a durable power of attorney? What is do not resuscitate order? What does that really mean? And if you're in the conflict world, a lot of what we're doing is many people are training physicians. I want to train patients. I want to train those patients how to address the conversations with their physicians when they're not doing it. So think about, my assignment would be, what do you wish? And then revisit it as often as you need to and have the conversations. Like those participants say, when you allow that to happen, you're really making room for conversation. It doesn't have to be, depressing or a tragedy. The reality is we're all going to die, and some of us are going to die in better ways than others. And the goal would be to close that gap, right? How can we all get those wishes that we need? So that would be my assignment. Really reflect upon what's life-giving and what do you want for the end of your life. Who do you want to be with?
Thank you for doing such a wonderful work that you're doing there in Nebraska, folks. You can find Dr. Jackie Guzmán. That's Font, F-O-N-T hyphen Guzmán, G-U-Z-M-A-N. I call you Jackie, but it's Dr. Jacqueline Font-Guzmán. And you can find her at the Werner Institute, which is part of Creighton University. And you just simply go to www.Creighton, that's CREIGHTON.edu, and certainly search for her name there. And again, it's all about the conversation.org is a wealth of information. There's videos, research, education, and it's all about educating, advocating, and empowering, in particular Nebraskans, but I'm sure that people will get a lot from engaging these conversations about advanced care planning. And so there's a number of resources there for that. Jackie, thank you so much for being part of the program. Do you have a final message, and what is that final message for our listeners?
Patty, I do want to thank you for having me in the program. This has been a lot of fun. And my message is, it's the same that I just said. Just go out there, think about how to live a good life so you can have a good death, because it seems like that's what it's all about at the end of the day. And try and be aware of the privilege you have or of the privilege you don't have. And how can we close that gap?
I really like that. What is the privilege you have or you don't have, and how to close that gap? Thank you so much, Jackie, for being part of the program. Everyone in the chat room who've come in and out of the chat room, thank you for listening, and those in our Twitter feed. And thank you, everyone, and thank you again for kicking off our June series, Jackie. And hopefully we'll have you back again, because this is a really rich and long topic.
Thank you.
All right. Good night, everyone. Thank you for listening to the Texas Conflict Coach. We hope you enjoyed the program. You can find all of our podcasts archived to listen at your convenience at texasconflictcoach.com, or download the podcast at iTunes or Stitcher Radio. You can also become a Facebook fan of Conflict Connection or Twitter me at TX Conflict Coach.